All right, welcome to The Explainer. Today we are diving straight into the updated 2025 CAP guideline on HPV testing and head and neck cancers. If you're in training or already in the clinic, think of this as your high-yield rundown of the updates you absolutely need to know.
This quote from the guideline really says it all. The word transformed is perfect, because the rise of high-risk HPV hasn't just tweaked things. It has completely rewritten the rulebook for how we diagnose, stage, and treat these cancers. So here's our game plan. We're going to walk through the guideline by answering the 3 big questions you'll face every day. Why are we even testing? Who exactly should we be testing? And how do we do it right? Okay, so first things first, let's set the scene. We are smack in the middle of this massive epidemiologic shift. The traditional head and neck cancers, the ones tied to smoking and alcohol, their numbers are dropping. But HPV-driven oropharyngeal cancer is absolutely surging, especially in places like North America and Northern Europe. Now, if you take away just one thing from this whole explainer, let it be this. HPV-associated cancer is not just another subtype. It's a fundamentally different disease. We're talking about a different biology, a much better prognosis, and it's even staged with its own separate system. This one idea is the bedrock of the entire guideline. So that brings us to the big why, right? Why do we test? We test because the answer has immediate, profound consequences for the patient. This isn't just an academic box to check. The HPV status directly dictates staging, treatment, and ultimately a patient's chances of survival. And the clinical stakes are huge. HPV status is one of the most powerful predictors of survival we have. A positive result could make a patient eligible for a clinical trial, looking at de-escalating treatment to reduce side effects. And think about this. A patient walks in with a neck mass, and you can't find the primary tumor. A positive HPV test is a giant clue, pointing you straight toward the oropharynx. Okay, so let's get down to brass tacks. Who absolutely positively needs to be tested for HPV? The good news is the guideline is crystal clear on this. Rule number 1, and it's a simple one, test all newly diagnosed oropharyngeal squamous cell carcinomas, period. This isn't optional. It applies across the board, no matter the subtype, whether your sample is from the main tumor or a MET. And here's another really strong recommendation. A patient presents with metastatic squamous cell carcinoma in a neck lymph node, but the primary tumor is nowhere to be found. You test for HPV. A positive result is a total game changer. It points strongly to a hidden oropharyngeal primary and guides the entire rest of the workup. Now for the flip side, which is just as important. Knowing when not to test. The guideline strongly recommends against routine testing in other sites, like the oral cavity or larynx, just for prognosis. Yes, HPV can be found there, but a positive result doesn't mean the same thing. It doesn't carry that same survival benefit and could actually end up confusing the clinical picture. All right, so you know who to test. The next logical question is how? How do you actually do it? The guideline lays out a really clean, easy-to-follow 2-step algorithm. Your go-to test, your day-in, day-out workhorse, is P16 immunohistochemistry. It's everywhere, it's cost-effective, and it's an excellent surrogate marker. In a nutshell, it detects this massive overproduction of the P16 protein that happens when the HPV E7 onprotein goes wild and messes with the cell cycle. And the guideline gives us a crystal-clear, standardized cutoff. For a result to be positive, you need to see staining in at least 70% of the tumor cells. And we're not talking about just any faint signal. It has to be strong, diffuse, block-like staining in both the nucleus and the cytoplasm. But, as great as P16 is, it isn't perfect. It's a surrogate, after all. Its accuracy really depends on the situation. So that begs the question, when is P16 not enough? When do you need to pull the trigger and order a more specific confirmatory HPV test? Well, the guideline spells it out for us. You're going to want that extra confirmation in a few key scenarios. For instance, if the staining is kind of wishy-washy, or if the tumor is in a low HPV prevalence area, or it comes from a non-tonsillar site like the soft palate. In those cases, the risk of a false positive P16 is higher, and you need to double-check with a direct HPV test. So when you do need that confirmatory test, what should you order? The recommended methods are the ones that detect a transcriptionally active virus, like RNA in situ hybridization. What's explicitly not recommended is DNA ISH. It's a big no-no because it's just not sensitive enough to be reliable. Let's shift gears now and look at two special situations where the guidelines got a pretty significant update: sinonasal cancers and those tiny fine needle aspiration specimens. This is a really big change in the 2025 update. We now have a conditional recommendation to routinely test sinonasal squamous cell carcinomas for HPV. Why? Because we have more and more evidence showing that, just like in the oropharynx, being HPV positive in these tumors means a better prognosis. But, and this part is absolutely critical, you do not use the same testing algorithm as you do for oropharyngeal cancer. You just can't. Because the overall rate of HPV is lower in sinonasal cancers, the positive predictive value of a P16 test alone is pretty poor, something like 52%. So the guideline says to go directly to an HPV-specific test, like RNA-ISH, right from the start.
And here's another crucial distinction for your day-to-day practice, this time for fine needle aspirates. The bottom line is, on these smaller cytology samples, P16-IHC just isn't as reliable. So the recommendation is to bypass P16 and go straight to a more specific HPV test from the get-go.
Finally, let's wrap up with a really exciting glimpse into the future. The guideline gives us a peek at what's coming down the pike for diagnostics in this field, and it's pretty cool. We're talking about circulating tumor HPV DNA, or ctHPV DNA. You might have heard it called a liquid biopsy. The whole idea is amazing: a simple blood test that can pick up tiny fragments of viral DNA that the tumor has shed into the bloodstream. I mean, the potential here is just transformative. Imagine being able to monitor your patient for recurrence with a blood test that can detect a rising signal months before you could ever see anything on a scan. Now, it's not ready for routine use just yet, but for surveillance, it's quickly becoming a very powerful tool. And this really leaves us with the big question to think about, doesn't it? As these liquid biopsies get more sensitive, more accessible, and cheaper, how are they going to completely transform the way we manage head and neck cancer, from the very first diagnosis to long-term follow-up? It's going to be fascinating to watch.